Hi, good evening, everybody, and welcome to Michigan Institute of Urology. We do these serial lectures, and tonight's lecture is on bladder control issues. I will admit that originally when we did this presentation, we had just lady patients in mind, but a lot of these also apply to men. So I will really try to differentiate if there's a place that only applies to ladies or only applies to men, but certainly if you have any questions along the way, feel free to insert them and I'll do my best to answer them. When I will skip this because this picture is from a long time ago. I'm originally from the West Coast and I moved to Michigan to train, stayed locally and have really enjoyed raising my family here. It's been a great place to grow professionally and really have met some wonderful professional and personal friends here. So we decided to stay, and here I am 30 years later. So even though I'm a native of Southern California, I think I've probably lived in Michigan more than half my life at this point. Just as an introduction, when we talk about how the urinary tract works, I try to put it in terms of plumbing. You know, if you think about plumbing in your housework, if you think about plumbing in the toilet, and if you think about how the pipes are connected, it gets a little bit easier to understand. The kidneys are shaped like kidney beans, and they produce urine. The urine basically flows down these tubes called the ureters. These are the pipes. You store them in the bladder. In women, the channel is a little bit shorter. You end up urinating through the channel here. In men, the channel is a little bit longer. And right underneath the bladder is the organ called the prostate. So all of this works together. So the kidney knows that the urine is going to be carried down. The bladder knows its job is to store the bladder. The urethra knows its job is to let the urine flow through. There's a little sphincter here. There's a little sphincter underneath the bladder that kind of controls some of your flow and allows you to hold your urine when you cough or exert pressure. It doesn't show it on this picture, but it becomes a problem when it's damaged in certain medical conditions and people leak when they exert pressure. So for all of their urine to sort of stay in and have good control, all of these components need to work together. And when we look at common bladder problems, and you'd be surprised, there's a staggering number. When you look at other medical conditions, you'll realize that almost a third of people in the U.S. suffer from incontinence or leakage of urine, and that's a lot. That's a third. Is if you look around you in a room full of 10 people, then 3 people in there have a leakage issue. So it is really something that's very common. It's something that we didn't talk about till maybe 10, 15 years ago, but it's something that since we have options for, people are more willing to come forth and say, okay, what are my options and where can I start? Or I've tried something I don't like. So we really do have a lot of options for leakage at this point. And leakage comes in several kinds. And I want to separate it from an overactive bladder because an overactive bladder is a bladder that has to go all the time. It feels like you want to go. You're looking for the bathrooms. You're going frequently, but you don't necessarily leak. You can hold it till you get to the bathroom. And that needs to be separated from one that leaks. Leaky bladders can leak either because when you gotta go, you can't control it. So that's more of an urge incontinence, or stress incontinence when you laugh, cough, sneeze, bend over to pick something, and then you leak. It's important to try and separate those two because the treatments are very different. Interestingly, a fair number of people have both kinds when it comes to women, and you end up treating one and the other kind surfaces, and you end up really requiring several types of treatments if you leak a fair amount. Overflow incontinence is really a misnomer because that's really when your bladder's full. So think of a bucket, think about the bucket being full, and think about water just kind of pouring off the sides. That's an overflow incontinence. The problem really isn't that you're leaking. The problem is that the bucket's full. So very similar symptoms, but different reasons, different causes for them. So, you know, we quite frankly try to differentiate that early on in treatments because their treatments are very different. So like we talked about, the sudden urge to urinate, going frequently, thinking about bathrooms all the time when you're out there is really something that's called OAB, or overactive bladder. Normal people go anywhere from 6 to 8 times in a 24-hour period. So it's not good to be on either side of that curve. If you are urinating 3 times a day, and I see this mostly in nurses, teachers, healthcare professionals, letter carriers, daycare workers, you probably need to urinate a little bit more. It's not good for your bladder to be stretched out that much. It's not good for you to hold urine that much. On the flip side of it, if you're going every hour, it's really hard to remain at a job or remain at doing what you're doing. So we tend to treat both ends of those. The overactive bladder end is when you can't hold it. You are going more than 8 times a day. If you leak on top of that, that becomes OAB wet, or urge incontinence. And we talk about sleep being disrupted 2 or more times. Many patients come to me and say, you know, I would like to have a full night of sleep. And the problem is you have to remember how your body works. You have to remember your body makes urine at nighttime. In fact, as you get older, it makes more. And so you really have to allow your bladder to work and urinate. And sometimes it requires you to wake up a few times a night to empty out your bladder. It becomes a problem when you're waking up 4 or 5 times, or you can't fall back asleep, or it's disrupting your energy the next day. So those are the kinds of things that sometimes we're able to work. So let's go on to our next slide. So urge incontinence is actual leaking. So you have the sudden urge, you feel like you have to go to the bathroom, and you're leaking on the way. These are more common in women. It can be seen in men as well. As the prostate grows and causes trouble urinating, you know, the flow might be diminished, but it's not uncommon for men to have urgency and overactive bladder type of symptoms, and even urge incontinence. So this is certainly a condition that I see both in men and women, although it's more common in women. And again, I want to make sure I'm clear on the overflow, because your bladder is really full, and what you need is to empty the bladder, whether it's with a temporary catheter or with some medications, or with a straight catheterization where you temporarily, or maybe for a long term, we have to wear a catheter. Those we have to really separate early on, because our treatment's really very different and not related to an overactive bladder or stress incontinence. So the bladder, so we talked about the kidneys, we talked about the urine coming down these pipes. We need to spend a couple of minutes talking about the bladder. The bladder is basically one big muscle. So as it squeezes, it pushes urine out. And as it relaxes, like a muscle would relax, it allows you to hold the urine and keep it in place. The idea is to hold it in place till you're ready to go to the bathroom, till your brain and your bladder can communicate and they can decide it's appropriate for you to go to the bathroom. It becomes a problem when your bladder wants to go and your brain cannot tell it it's inappropriate, and you can end up having an accident. And those are some of the things that we see after strokes, for example, or people with diabetes. They have bladder cancer listed here, but I can tell you it's not the first thing I think about when someone comes into my office and is leaking. And that's whether male or female. You know, in a male, you think about an enlarged prostate. In a female, you tend to think of an overactive bladder. Some of the underlying conditions can be diabetes, nerve damage from either previous pelvic surgeries, back surgeries, strokes, some spinal cord disorders, Interestingly, menopause and estrogen deficiency can really play a role in an overactive bladder and how the bladder can function. When we talk about spinal surgery, we talk about herniated discs. We talk about sometimes you have congenital issues. We talk about, and so we're not talking about a pulled muscle. We're actually talking about something that involves the innervation or the nerves to the bladder. Medications, we get into what we call polypharmacy as we get older, and we're on multiple medications. So I always ask for that list just to make sure that they're not on medications that can cause either too much urine production or difficulty with bladder muscle function. To give you an example, like a diuretic, if someone is taking a water pill multiple times a day, they're going to make a lot of urine. And so the idea isn't to try and find a treatment to lessen that urine production. They need to be on that diuretic for a reason. The idea would be to find a way for the bladder to accommodate that urine with control so they can hold it till they get to the bathroom. One of the more common things that I tend to pull the trigger on is caffeine, and I guarantee you'll still be nice if you're not drinking 10 cups of coffee. I strongly believe that caffeinated beverages, which are the teas, the coffees, the Mountain Dews, Cokes, the Pepsis, really stimulate the bladder, and once you have patients really kind of let back a little bit and sort of control that a little bit, the urination actually gets a lot better. Obesity is kind of a double-edged sword. There's good literature that shows if you lose 10% of your body weight, your leakage can get better up to 50%. And that's a lot. I mean, if you're 200 pounds, you are trying to lose 20 pounds just to improve your leakage. And that's for all comers. That's for any kind of leakage. We try to explain that to patients. The problem becomes if you're leaking when you exercise, you're not going to want to exercise because you're going to leak all the time. So that's a situation where we would work with each other to try and figure out if really our goal is weight loss, how can we stop the leakage temporarily till the weight loss occurs. Nerve-related diseases like strokes, Parkinson's disease, multiple sclerosis is another big one. Those are some of the nerve-related things that can cause bladder control issues. Pregnancy and labor trauma during childbirth, that tends to create more stress-related incontinence. Radiation therapy doesn't immediately cause a problem. It causes a problem down the road. And I see this commonly in men, it's after prostate cancer or maybe colorectal cancer. In women, it's after a gynecologic malignancy. In our specialty, we see it after bladder or prostate radiation. I will say radiation over the years has gotten much better. They really target the organs much more specifically so that the radiation just goes to that organ. But you still have some effects of radiation, and you might not see that for some time after. You don't see it immediately. There's usually a time lapse with that. Any kind of pelvic surgery, so pelvic prolapse surgery, gynecologic type of surgeries, bowel-related surgeries, colorectal surgeries, some of them that occur in the pelvis can have impacts on control issues. And anytime you go to a urologist's office, they're going to ask for a urine sample, and we're checking to make sure you're not infected, because that can certainly cause an infection, and infection can certainly cause some leakage issues. We talked about pelvic prolapse. I'm amazed by how many female patients don't necessarily know they have prolapse, and you find on an exam, they're not sure what is prolapsed, and when you examine them, you know, you realize what component is prolapsed, whether it's the bladder, whether it's the uterus, the cervix, the rectum, and certainly things being out of place can certainly affect how they work. So how do we really diagnose these things? So the first thing we do is we take a very good history and we do a very good physical. So your physical exam, if you're a male, will include a prostate exam. If you're a female, that will include a pelvic exam. And during that time, we'll have you cough, see if you have any loss of control of urine. Don't be embarrassed. mean, this is what we do day in and day out. And we're looking to see if you have any leakage associated with cough. And that's really the premise for stress incontinence. The history part of the exam is what determines really whether you have an overactive bladder or potentially a mixed type of incontinence. Urodynamics is an in-office test where they put a small soft wire through the channel you pee out of. And as I explain it to patients, it's like an EKG of the bladder. You're looking for whether the nerves and the muscle tone of the bladder is normal. You're looking for how the bladder functions when there's fluid in it. You're looking to find out, it gives us a lot of information in terms of the functionality of the bladder. And it's almost like pieces of a puzzle. You got to make sure it looks okay, it functions okay, and that there's no anatomic problems. And all those things go into play with when you look at incontinence in patients. Sometimes there might be a cystoscopy where there's a small, soft camera placed into the channel. This can be done in men and women just to make sure the urethra looks normal. Everybody gives a urine sample, and everybody gets a postvoid residual, which is where they look to make sure the bladder is empty. And that's usually done with an ultrasound. We try to stay away from catheterizing people, although quite honestly, some people, the ultrasound value is not accurate, and you have to end up catheterizing them to make sure you don't have that overflow incontinence issue. Okay, there's some questions coming up, and I just want to quickly answer Yolanda. So what is the average time after bladder radiation where you'll get some leakage? You know, everybody's different, and it depends on the type of radiation and the duration, but usually it's a couple of years. And it could be anywhere up to 5 years. The tissue changes with radiation. It becomes more stiff. So if your bladder muscle, which is supposed to relax and hold your bladder urine at a low pressure, becomes stiff after a number of years as it's reacting to radiation, you'll begin to see some issues. But I'm going to remind people with radiation, you know, it's curing a cancer. So if at 5 years you're leaking, but you're cancer-free, I mean, leakage is manageable. And I always remind people that the basic gist of that is to help them with their cancer. Let me move on a little bit. I like to use logs. If any of my patients are on this, they'll know what this is. This is a voiding diary. This is what tells me how much you drink, how much you urinate, and whether you're leaking. It's a lovely diary. I even have a hat that measures how much you drink and how much you pee, I'm sorry. And really, what that tells me is how much goes in and how that translates into how much comes out. Do you have an issue mostly at nighttime? Do you have an issue more at daytime? Are you really drinking that 4 liters of Diet Coke that we asked you to maybe temper down? You know, are you drinking 100 ounces of water a day? This is a very good tool to try and look at your patient and see if there's something easy you can do without starting medicines, or maybe augment if you've already started medicines. It's a great tool, and I usually do a 3-day diary, and it gives me an idea of what you're drinking, how much you're drinking, and how that gets translated into your urination pattern. And it's important because it happens at home. It's not an artificial thing we do in the office. And it kind of tells me a little bit about what I need to fix at home and not necessarily what I can identify in the office. So easy things to do that you can do. There's lifestyle changes, and those are very easy to do. We'll get into the list. Then we go on to oral medications. There used to be some patches on the market. I think some people can still order them at Amazon or online. We've tried to get away from the patches. So oral medications come in multiple forms. I'll get into that a little bit. There's testing that we talked about. And then if none of that works, or there's a reason you don't need to be on medicines, or there's side effects, we move on to what we call third-line therapy. And those are some of the procedures that you see listed. So let's move on to our bladder pathway control. I'll get back onto what the individual components are in a minute. So as you come in with your initial evaluation, everybody gets a diary. We talk about things you can do like limiting caffeine, limiting excessive water, not drinking before you go to bed, not having constipation. We try to go through the easy things and try conservative treatments, and those are lifestyle changes. Those are, we might ask women to start Kegel exercises or refer them to pelvic floor physical therapy, which is really quite well done with specialty trained physical therapists. Depending on what else is going on, patients come to me usually either on a medicine from their family doctor, or I'll start them on one if I feel it's indicated. I don't necessarily have to always look at the diary. You can sort of tell by doing an exam, doing a history, whether it's appropriate to start a medication. There's a 1-month follow-up with either myself or a nurse practitioner. If the pills are working just a little, or the pills are working but you need to change it because of insurance purposes, or the pills are not working at all, we go to a second type of a medicine just to have a different type of a medicine, and then we see you a month later. If nothing's working, that's when we start our evaluations. We can order urodynamics, which is that EKG test of the bladder we talked about earlier. We might order a look inside the bladder if it's indicated. And then if the pills aren't working, or there's reasons we have to take you off of them, such as side effects and interactions and really reasons beyond either one of our control, then we look at something called third-line therapy. And third-line therapy these are treatments. These are procedures, not necessarily invasive, but things that get you off the medications. So I'll start down here with percutaneous tibial nerve stimulation. That's probably the least effective, but the least invasive. It involves putting a small, kind of like a small, almost like a needle. It's very painless, above the ankle, and you tap with an energy source on the nerve, the percutaneous, the tibial nerve, and it's a 20-minute treatment once a week. You come in, put your foot on the chair, we put it's almost like an acupuncture needle, and you read a book, there's no pain involved. After 20 minutes, the needle comes out, you go home. We repeat the 6 sessions. By the 6th session, the brain and the bladder, they've communicated, and if it's gonna work, it's gotten 50% better. You can have a second session, and then after that, it's once a month. It is a little cumbersome, but it is our least invasive. It's something that's done in the office. And unfortunately, it's the furthest away from the bladder. So in its current state, it's maybe not the best option if you're having a lot of problems. Botox injections. Botox is something that ladies are familiar with, men too, for that matter, and it basically deadens or paralyzes the nerve to the muscle where you inject it. So we tend to inject it throughout the bladder in a particular pattern. This can be done in the office. This can be done at the hospital. It could be done under twilight, but it basically kind of deadens where you inject it inside the bladder, so it can't have a bladder spasm. It has to relax that part of the bladder, and it allows you to hold it better. Neurostimulation or neuromodulation is a technology that involves delivering a message to the nerve, around the nerves of the bladder for it to slow down. It's been used for patients that have an overactive bladder and need a neural control, so higher up in the area of the spinal cord where the nerves to the bladder are. It delivers it's almost like a little pacemaker that you put in the fat in the butt cheek, and it basically tells the nerves to settle down. It's more like a remote. You can turn it up, turn it down, you can change the volume. It's very handy, and it comes in several models, several types, and it's really revolutionized how we treat some of our refractory patients. But I want people to understand, we don't think we can fix everybody. Our goal here is to improve your lifestyle. Our goal is for you to feel comfortable enjoying the things that you do. I mean, I have patients who don't leave the house. I have patients who can't go to church, don't like going grocery shopping because they're in the bathroom all the time. So they might be okay wearing 1 pad a day. The idea is for them to be comfortable enough so that the bladder doesn't control some of their social situations. So lifestyle changes, just to go in a little bit more detail. Hydration, it's always an issue because I'm always fighting these weight loss places that say you should be drinking half your weight in fluids. Well, I mean, the reality is for healthy kidneys, you probably need to be drinking 50 to 60 ounces of water a day. So you don't need to be drinking coffee, tea, pop, a Mountain Dew. A cocktail is okay. A glass of wine actually is okay. But you shouldn't be drinking 100 ounces of water a day unless you're a yoga instructor or an exercise instructor, or you have a job where you get dehydrated very fast. If you drink that much, you're going to urinate that much more than the normal 6 to 8 times in a 24-hour period. So quite honestly, that's an easy fix. It kind of goes along with the diet too, because you can eliminate some of the caffeine. When they mention diet here, it's really an introduction to weight loss. If you can get on an exercise program, if you can eliminate some of the extra stuff in your diet, that would really help you in the long run. Bladder retraining and controlling urgency are some things that we do early on. If you can, when you get an urge, if you can hold on to it and not necessarily immediately go to the bathroom early on in the course of this, you can control your bladder, train it to just hold it a little bit longer. It becomes an issue when you hold it all day. And I see this in some of the healthcare professionals I take care of. It's okay to hold it a little bit. It's not okay for 8 hours. We try to empty the bladder every 3 hours if we can, or just to keep it healthy and make sure that there's no urine remaining in it. This is a stage that I might say, hey, go to pelvic floor physical therapy. There's a great physical therapists that are trained, and they do a fair amount of work on pelvic floor strengthening. Kegels are great, but I'd say 90% of people fail at them because they're not doing them correctly. And that's where pelvic floor physical therapy comes into play. And I strongly, strongly recommend, if someone's interested in that, to seek the advice and the treatment of a pelvic floor specialist. Keep in mind, these are early on. So if you're into 10 pads already when you decide to do physical therapy, that's probably not going to work. But if you're into 1 pad, 2 pads, maybe you have just a little bit of a problem, then that's the time to try and start physical therapy. Medications come in 2 forms for the bladder. Ones that are called anticholinergics. They belong to a class of medications that traditionally have always been used for overactive bladder. There's 8 or 10 of them on the market. Majority of them come in a brand name and a substitution form, a generic form. They also come in an extended release or several times a day kind of a dose. And some people, these are easy things to fix. Some people take an extended release. It's once a day. It works well for them. Some people need a little extra dose before bedtime and a little dose in the morning. So those are patients that I would say need kind of the dosed kind of a treatment. And the idea with the medications is that you should have fewer trips to the bathroom. Your urgency episodes should be better. You shouldn't be anxious about looking for the bathroom. And you should have results within the first month of taking them. The second type of medicine, which is a little bit newer, works on a different receptor in the bladder, and it does not have some of the traditional side effects we see with the anticholinergics. The overall side effects with the anticholinergics are the dry mouth, the blurry vision, and the constipation. This second type of medicine, which is the myrbetriq and the gemtesas, can be associated with hypertension. We kind of pick those people out early on because by looking at their list of medications, we know what interacts with what. So depending on what else is going on with one's medical condition, these would be appropriate pills to start if you don't have any underlying conditions that are contraindicated, or if you haven't tried medications from another source. So if the pills don't work, then we go to third-line therapy. So third-line therapy is, and this is something that's, by the way, occurring all across urology. When you look at male patients with prostate meds, we've had prostate medications for 30, 40, 50 years. They've used high blood pressure medications to help with the prostate, and they have specific prostate medications. But the idea with some of our medicines is not to take them long-term. We are finding out that some of these medicines that you take long-term might not be good for you down the road. So the idea is take the medicines if it works for you after a while, and providing that you have no side effects, no contraindications, you need to consider coming off of them and looking at some procedures that can be done to just control the problem without taking a pill every day. So sacral nerve stimulation is a pacemaker we talked about. It's a very small pacemaker. It's MRI friendly. There's several models out there. It's implanted not near the tailbone, but actually in literally the fat of the butt cheek. And it's not where you sit. It's higher up. It's not near the belt line. It's put in a place where it's not touching any article of clothing, like the belt or the underwear. It's and done deep to the skin. So it's not something that you should feel unless you're very thin. And sometimes those people feel that. We have smaller models, we have bigger models, we have rechargeable models. There's quite a variety to choose from, and everybody's going to be different. And it basically taps on the nerves and the area around the nerves and tells them to settle down. If your bladder is going all the time, really what it needs is some impulse to tell it to, okay, settle down. You don't have to have a spasm. You don't have to have a feeling of urgency all the time. And the good thing about these that has changed over the last 20 years is we don't have to put it in to see if it works. There's actually testing kits. So with an easy office procedure, you can put in a testing kit. You'll know in the first couple of days whether this is going to work. The testing kit gets removed, and the procedure can be scheduled as an outpatient. So it has really allowed us to kind of move forward and pick out patients who we think are going to respond well to this. More importantly, as of several years ago, these are MRI safe. So these have been around for about 25 years. They started as a very, a device that was the shape and the size of a cardiac pacemaker, but as the years have gone by, it's gotten smaller, it's gotten MRI friendly. The lead that they put in, the wire that is attached to it is much better, it works much better and stays in place much better. So I'm actually very happy about this type of therapy. And more importantly, it's MRI safe. So for those who have bad backs or bad hips or things that don't allow you to get an MRI, this is the kind of device that you can have, and it would allow you to still get the testing that you need. The posterior tibial nerve stimulation, this is kind of what we were talking about. I don't know if you guys can see. There's a little acupuncture needle right here that's going above the ankle. And you kind of sit in the chair. I tell patients to bring a good book, and we read something for 20 minutes while there's a stimulation to this nerve. The stimulation gets carried up, it communicates with the brain, which communicates with the bladder, and it ends up in a relaxation of the bladder. And the sessions are anywhere from 20 to 30 minutes. We start with 6 weeks. If by 6 weeks you have a 50% improvement, you can get your full 12 weeks in and then graduate to a maintenance, which is once a month. These are great non-invasive treatments, but it is time consuming. So somebody who's working 40 hours a week, it's very difficult to have them come into the office once a week for 12 weeks. This definitely takes a special population who has the time to invest in this into the office for 3 months. The last one is going to be Botox, and Botox has been used for many, many things. It was FDA approved for a while back. and you inject it directly into the bladder muscle. Depending on your treatment, it's 10 injections or 20 injections, or usually people are somewhere between 10 and 20 injections, and it basically paralyzes the muscle you inject it into so that you can have that part of the bladder relax, and you'll be able to hold your bladder better until you're ready to empty it out. So I want to just go back. This discussion is an individual discussion with a patient. We have a pathway, we have areas that we sort of discuss, but quite honestly, when a patient comes in, no two patients are the same. They're not made the same. They don't have the same medical history. They don't have the same medications. They don't have the same social issues. And so this is a discussion that's a two-way discussion. I can look and make sure that there's nothing else going on that really needs to medically be treated so that you don't get sick. But part of the treatment and part of how we proceed on some of these treatments is a two-way discussion, because this is a quality of life issue. This is I want to improve my life so I can, maybe wear less pads, have more confidence when I go out. So I discuss these briefly, but I don't want anybody thinking all of these apply to everybody. It really is sort of a, if you want to think about it, like a la carte menu. Everybody kind of gets to pick what works for them as long as it's safe for them. So I'm going to end here. We have some questions. There's a question: my mom never had incontinence issues until being hospitalized for 2 months due to a spinal cord injury. Are there things other than pills that can help strengthen her bladder? So the problem there is if you have nerve damage because of a cord injury, the nerve can't be replenished. There's not medications that will help. We can control it better. We can help. We have to identify what the problem is to begin with. So these are people who do get urodynamics, but we have to try and figure out, is the issue one where the bladder is overactive, or is the issue one where the bladder can't even squeeze it out? The nerve stuff, the nerve injuries are a little bit more cumbersome. That's not a start your medication on the first visit. That really does require further testing so that you can see if you have options. Some of the nerve issues are permanent, so you can't really undo that. So you move on to how can I help empty the bladder or keep the bladder healthy with other modalities besides pills. I hope I answered that question there. Any other questions? We did end a little bit early, so I'm happy to take any questions if you'd like. Okay, I'm sorry, I was going the wrong way. Okay, I'm so sorry. There's a lot of them, but I was looking at them differently. Okay, I had a bladder suspension 32 years ago. Sorry. Let me get to this question. I had a bladder suspension 32 years ago. My overactive bladder and incontinence are worse in the last 2 years. Anything besides, if you had a bladder suspension, then you need an exam. So the old bladder suspension that they did 32 years ago is very different than what we do now. And so number one, people need to make sure that the suspension hasn't fallen back down. You might not feel the prolapse the way you did many years ago, but you need to make sure there's no component of it falling down. And so that's an exam. And losing 10% of your body weight in that situation, depending on what you're starting out with, would be advisable if you want to get it fixed. The problem is that if you have an anatomical problem where the bladder has dropped again, losing 10% of your body weight isn't going to help that. This is a situation where you would want to make sure that your anatomy is okay. I'm very pro exercise, but if you've had previous surgery, I mean, the first thing you need to do is just to make sure that it hasn't recurred. Second question, is prolapse bladder normal after, I don't know what BS surgery is. What is BS surgery? I don't know. Who's Linda? Linda, if you could repeat that question, is a prolapse bladder normal after, I'm not sure what you're referring to for BS. So ask me that again. Can you reverse prolapse through exercise? If you have just a very little amount of prolapse, you can do physical therapy. You know, we stage prolapse, just like you stage the cancers 1 through 4, we stage prolapse. And if you have a low stage 1 and 2, you can't reverse it completely, but you can certainly help it become less symptomatic. I want to see if, okay, so I'll wait for this person to answer me back. What can you do when on your period? I tend to leak more when, oops, sorry. I tend to leak more, for a while after during my period. Yeah, when you have a lot of leakage that's very specific to your cycle, you need a GYN evaluation. You want to make sure you don't have a fibroid. You want to make sure it's not related to the position of your uterus. You know, when you are about to start your period, the uterus tends to get a little bit larger, so you want to just make sure that it's really not an anatomical issue. If you have only leakage, that could be related to your cycle. Next question. I had a fall where I fractured my coccyx, my tailbone. I had a bladder suspension 5 years ago. I'm having stress incontinence since my fall. Is my incontinence due to my fall? Please advise. There's a difference between prolapse and leakage. Many people can have a bladder that is prolapsed, a uterus that is prolapsed, or a rectum that's prolapsed and not leak. And many people have stress incontinence where they leak, where they laugh, cough, or sneeze, and they don't have prolapse. So if you have a fracture of your coccyx and you had a bladder suspension, I would recommend that you, first of all, see your professional and make sure that the two are related, meaning you have potentially something that's fallen back down, or you have independently stress incontinence. Those two don't always go together. They can be very independent things. In addition, if you fractured the tailbone, you want to make sure you don't have any numbness or any nerve damage that could affect how you have controlled the sphincter or the bladder muscle. So there's a few components there that need to be looked at in that question. How much should we be drinking? You know what? I think that's a great question. So Barb, thanks for asking that question, because everybody's different. And, you know, my kids are swimmers, so my kids were drinking 120 ounces a day, and, you know, at 16, they're not urinating once an hour. But if I drink 120 ounces a day, I guarantee you that I'll be in the bathroom every hour. I think everything is relevant. 50 to 60 ounces of water a day. There are conditions where your kidneys are slowing down, or you have a kidney condition. Yes, they will make you drink more, but then you're going to urinate more. There are conditions where you are on a water pill, or you have to drink more for constipation, for example. Well, yes, you're going to urinate more, but the idea that I have to be drinking half my weight in water for weight loss, I've spoken to several counselors at Weight Watchers, and honestly, they don't recommend that as much. And if you drink that much and you like water, because people like water, and you don't have a urinary issues, please continue to do so. But if the urination issue is an issue, then the first thing you should do is try to limit and try to come down to 50 to 60 ounces. So next question, since PTNS worked so well for me, I was curious about updates. Yes, Sophie, thank you so much for asking that question. So PTNS is the needle that you put in the ankle, above the ankle, and the pacemaker is what goes into the butt cheek. And there's a combination device coming out where you'll be able to actually place a very small device inside the leg above the ankle. It goes again skin deep, so it's not as visible. And it basically taps that nerve continuously with the same premise like the device does up higher to the spinal cord. That trial just closed. They're actually submitting their information for approval, and I think that will be a very good addition to the overactive bladder treatment offers, because the PTNS is cumbersome. Many people who have regular jobs can't take half a day off to come in, but to be able to have something that doesn't involve something going around the cord, I think is going to be a great addition. So more on that to come. We'll probably have information for that in about a year. So next question, I have MS and an overactive bladder. I have MS and an overactive bladder and all the incontinence things except for overflow. I cath and I take oxybutynin. I've done Botox, but I still go 12 to 15 times. Yeah, that is a problem. So oxybutynin, it's the one drug that we're all trying to get away from for a long-term patients, because it can be associated with memory issues. And if you have, if you're catheterizing, you can be given higher doses of Botox than someone who is urinating and needs to urinate. I would recommend you continue cathing. I would recommend see if you can look at your dose of oxybutynin to see if you can change it. There's several doses. Maybe you can go on a higher dose without some of the side effects. And you should be cathing on a schedule. It's hard to do if you're really cathing 12 to 15 times a day. But the goal here, you should be able to get into a position where you're cathing 4 or 5. And you either do it with medicine or you do it with a higher dose of Botox. But you would be a person who would need to get the full workup to see if the nerves are really affecting your treatments. I don't have a feminine diaper that is better than the other. I would go with what you can afford with your budget, which is costly. I mean, I have patients who spend $100 to $150 on diapers a month, and it's one of those things that it becomes costly for someone on a fixed income. Someone is asking about a TENS unit for the tibial nerve. That's another great question. Yes, there were some technology on this. We participated in another trial that looked at the TENS unit, and we initially had some good results. I don't know of a particular company that actually is only doing that. This was done as a trial, as part of a trial for us. It's something you can try. Remember, the nerve is deep, and some people deeper than others. So you would have to adjust that. But that has been done. But obviously, it's not as good as trying to stimulate the nerve directly. Dina asks if chocolate should be eliminated. Oh God, I hope not. Chocolate's great. If you're eating a lot of it, it's going to have some caffeine in it. But I don't have patients who eat so much chocolate that they have an overactive bladder. If you want to take it in moderation, because you are eating a lot of it, you don't have to eliminate it, but you can eat it in moderation. Is it common to urinate more frequently after beginning the day's activity? No, I mean, a diary would help there. A diary would be very helpful in someone like for this question, because you'd know how much you're drinking, what you're drinking. If I had 4 cups of coffee in the morning, I'm going to be urinating a little bit more as the morning begins. The other situation here is it really stress incontinence? So you're becoming more active. You wake up, you go have your cup of coffee, your cup of tea, or your whatever, and you are now more active. So am I leaking because I'm more active? I'm picking things and going upstairs and lifting things? Well, that's stress incontinence. Or am I leaking more because I've just had 4 cups of coffee? So this is where a diary becomes very helpful in trying to determine that, because your treatments are very different. Melissa, at what point do you stop taking meds that's helping on and off? I think if your meds are not helping you every day, and you don't have the results you want after taking it a month at a time, you should probably look for something else. There's reasons why meds don't work. There's reasons why people's diets don't allow the meds to work. You know, meds will work if you've limited some of your caffeine and your fluids. But if the meds aren't working every day, there's no point in taking them. It's time to move on, look for other things to help you with, or make some changes. You know, do a diary and see where the issue is. What problem is best for sacral nerve? It's actually urge incontinence. It's overactive bladder, whether you leak or you don't, and then urge incontinence. Stress incontinence, there's no role for sacral nerve for stress incontinence. That's more of a sling or a Bulkamid, things that we really didn't touch on in this lecture, but that really doesn't work for stress incontinence. And then overflow or retention, there's certainly a role for sacral nerve modulation in people who can't empty fully. There's a group of people who can be tested to see if the message we deliver to the bladder nerve is one to actually work harder. And if that nerve is not working, if you stimulate it a little bit, then some people who aren't able to fully empty or empty can now empty. I certainly have my share of patients who, for myriad of reasons, couldn't urinate, and they're now urinating with an inner stem. So it's kind of nice for both of those. Will this treatment work with MS? You mean, if you're asking me about a sacral nerve modulation, the answer is probably not, because in MS, in multiple sclerosis, you have so many different things with the nerves that can affect the bladder. Right now, we don't have the best results for multiple sclerosis with sacral nerve stimulation. What oral medication is good for bladder spasms accompanied with pain? I think all of them, you know, all the oral medications, there's not one that's specific with in conjunction with pain. And I think the pain you're referring to is the bladder spasm pain. Because if you're having pain with urination, that might be an infectious etiology. That's really not something I would put you on medicine for an overactive bladder. So if there's a pain component to it, we tend to look at that a little differently than starting the medicines. How long does Botox last? Typically, it's anywhere from 3 to 6 months. Everybody's, again, individual. Some people have it wear off at 3 months. Some people have it wear off at 8 months. So I don't do Botoxes on schedule. I really try to tailor it and see how long it lasts for patients. And then we kind of go on a schedule based on what happens on their repeated injections. Dora asks, how do you treat a prolapsed bladder? Well, there's a bunch of different treatments. There's the conservative way, there's the surgical way, there's like a diaphragm type of a device you can put inside the vagina. It just depends on, you know, age, bother factor, how far out it is, and what else it's doing for you. So those are things that you might want to see us for if you feel there's a pressure or a bulge down there. Okay, does a person's foot and leg activity contribute to bladder problems? I ask this because of the PTNS treatment. I'm not sure. I'm not sure about the question, but I think what you're asking me is, if you're asking me why we put it down in the lower leg, that's because we can access the nerve down there better. If you're asking me about activity, you mean a runner versus a sedentary person, that's probably not the best place to put that kind of modality if you're a runner. If you're a little bit more sedentary, maybe a little bit easier to get it down there. But I don't think the activity contributes to bladder problems. What does contribute to bladder problems in the foot and the leg is swelling. So if you are a patient that has lower extremity, your feet swell up, your ankles swell up by the end of the day, you're going to be waking up a couple of times at night as you lay flat, and all that extra fluid goes to your heart and gets pumped into the kidney, and you make more urine. That's the very simplified version of that answer, but it's not necessarily the activity as it is the swelling. Can an aromatase inhibitor, that's a great question, Julie. So that is usually in reference to breast cancer. And so let's talk about breast cancer patients who go on medications and they acutely go into menopause versus someone who gradually goes into menopause. Vaginal atrophy, which we see in menopausal women, does affect bladder function. And the treatment of vaginal estrogen can be open to some patients, but not to others. So can you have an overactive bladder mildly after some of these medications? Yes, you can. It's again, a matter of how you treat it. Can lumbar stenosis cause incontinence? Yes, that's a form of spinal stenosis. So depending on which nerve is involved, since the nerves to the bladder are in the lower back, they can cause some form of incontinence. Is it normal to have pain in the bladder area with urgency to urinate? So that I would say it depends. The first thing you'd have to make sure is that you don't have an infection. If you have pain from a bladder spasm, and some people do, and in women it would be in the pelvic area, in men it might be pain at the tip of the penis from a bladder spasm. You just need to make sure that there's no infection or inflammation, kind of an etiology, before you decide this is overactive bladder. People can have, they describe it more as pressure, but if someone's got sharp pain with urgency, I think you need to look for other reasons. Which of these procedures are better for leakage versus OAB? You know, everybody's different, Melissa. Everybody needs to, again, we don't, just because you don't leak, we don't hold back some procedures. Everybody is very different. What's a little bit of leakage to some person is just an overactive bladder to another person. So none of these are, one is not better than the other. It's an individual thing based on what your actual problem is. Does the medication lose effectiveness over time? No, what happens is people forget and they drink more water, or they add a couple of cups of coffee or a pop. The medication generally doesn't lose effectiveness over time. You just have to make sure nothing else changes. It seems like I have issues when under stress. Yes, under stress. You know, stress. Some people, when people are stressed, some people feel like they have to go to the bathroom all the time. If you look at college students and you look at, an hour, half an hour before their exams, their final exams, everybody's going to the bathroom. So yes, stress can affect it. And the idea, again, is to try and do some sort of, make sure that you don't have anything else that is contributing to this in terms of your diet, your infection, anything else that can contribute, and stress can make it a little bit worse. And that's when you have to decide, is it a daily stress thing? Is it a certain time of the week, certain time of the month? And how can I go around that? I have a problem sometimes giving, medicines every day for someone who has a stressful situation that they can't get out of. Sometimes it's temporary until they can remove themselves from that stressful situation. Should we try to make our kidneys stronger or bladder stronger? Yeah. So you can't really make your kidneys stronger. You can be careful so that it doesn't get damaged with certain types of toxic drugs to the kidneys, and so you can be careful about those kinds of things. Can you make your bladder stronger? I think more importantly is not to let it get weak. So don't hold it all day. Try to go regularly. You can do Kegels if you want to if you think that helps. If you've had children and you've delivered, that's a good time to get into Kegels. It's a good time after vaginal delivery if you're having a little bit of a problem to get into pelvic floor physical therapy. I think the more important part is not to let the bladder go as opposed to making it stronger. It's easier to work on a bladder that's not damage from a muscle standpoint and a nerve standpoint than to take something that's damaged to try and make it work like it was, 25, 20 years ago. What do you suggest for estrogen deficiency? So we use vaginal estrogen all the time, whether it's estrase, it's a vaginal insert, it's a cream. It can come in a pill. You apply it twice a week. It's a pea-sized amount that you put up the vagina. And you'd be surprised how much helpful it is after even just a few weeks of taking it. For the first week, you have to take it every night, but then after that, it's usually a pea-sized amount or a small grape-sized amount twice a week. And by getting the tissue to be a little softer, by making the area vaginally maybe a little bit more healthy, it will help your bladder. It definitely helps with some of the urgency. What to do if you have a sphincter that doesn't close after prostate surgery? Yeah, that's a problem. That is an extreme form of stress incontinence, and that needs a workup. We do see incontinence after prostate surgery, even after radiation, where the sphincter doesn't close, and these patients are often wearing multiple pads and diapers, and so you have an option of either having a sphincter placed. They have artificial sphincters. There's male slings that can be done, but that's definitely a visit to the urologist. And really, none of the things we've talked about affect the sphincter. So these are mostly related to the bladder pathophysiology. So the sphincter after prostate surgery is very different and has to be handled very differently. How does IC correlate to OAB? So interstitial cystitis, or painful bladder syndrome, is, I tend to think about it as sort of a continuum. On one side of the fence, you have people who just have a little bit of overactive bladder. They don't have as much of the pain component. They might have a little pain with intercourse, but their bigger problem is overactive bladder. And on the other side of the continuum is severe overactive bladder and pain, pelvic pain, painful intercourse. These are the people who are urinating every 15 minutes. They have sometimes what we call an end-stage bladder. So those are two different populations. So OAB medications can be used in some of the people who have interstitial cystitis, who have a lot of the urgency frequency. Even if you have a little bit of a pain component, it might help if the pain is related to the bladder spasms. But if the pain is so severe and your symptoms are so severe that you're on the other side of the fence, you can try the medications, but they usually add something else to it. Sue has a question, when is surgery necessary? Oh, so Sue, I think you're the same person who asked about the sphincter. I think that's what that's related to. What do you do if you have incontinence and an overactive bladder? Well, I mean, those are very easy. You start with the medicines, and the treatment's very similar. You do the same behavioral management. You have the same treatment whether you're dry with just OAB or whether you leak. And you'd be surprised how responsive the leakage is to some of the treatments we've talked about. Okay, the problem is when I stand up, I can't control the flow of urine. Yes, so that's really called, sometimes I call that positional incontinence, where you stand up and you leak. Very commonly, that's an overactive bladder. And you can try starting some of the things we've talked about, but again, it's a full evaluation. At nighttime, you make more urine. So at nighttime, I'm not surprised that you're wearing a pad. If you make a lot of urine at nighttime, you either have to wake up to go to the bathroom, or you have to get a workup to make sure the size of your bladder can handle what you can produce at nighttime. So again, these are complex patient, and it encompasses everything we've talked about, starting with a diary, looking at a good physical exam, looking at some testing to see if there's an issue with bladder storage versus leaking. These are great questions. I had Botox 3 weeks ago, but I feel like it hasn't really decreased my frequency. So you must, Esther, make sure that you are still able to empty out your bladder. One of the side effects of Botox, and it's very rare, but it does happen if you do a lot of Botox, is you can't empty. So you feel great because maybe you can hold it, but when you go to check on the bladder, it's almost too weak, and it can't squeeze the bladder. So you end up having frequency because you're just urinating a little at a time. And you know, Botox is not the end all. Botox is the dose can be changed, how you inject can be changed. You just want to make sure if you're going frequently that you have ensured that you're not in retention. And the time for that is about 10 to 20 days. So that's about the right time frame. We talked about MRIs, implants being MRI safe. Can sciatic nerve issues, you know, I see more of nerve issues higher up and not necessarily with the sciatic nerve. I usually see it with higher up in the nerve root, but not necessarily with the sciatic nerve per se. So Linda, oh, bladder suspension 20 years ago. Ooh, I don't have the rest of that question. Could chronic constipation exacerbate loss of bladder control? Absolutely. And we also see this in children, males, females. If you have chronic constipation, you should really, really try and get that under control, whether it's with dietary supplements, stool softeners. Some people like to use magnesium. There's a smooth move tea, but you really need to get the chronic constipation under control. Number one, it affects how the bladder works. And number two, it'll affect some of the medications we could use that might work in your bladder, but they have constipation as a side effect. Okay, Linda, thank you so much. BS is a bladder suspension. Here, I'm going to go back to your question. I can find it. So is prolapse bladder normal after bladder suspension surgery? Well, no, you're getting bladder suspension, so you're getting your bladder suspension surgery so you don't prolapse afterwards. The problem with some of the prolapse surgeries that were done earlier, many years ago, is they would only suspend one part. So prolapse surgery, you know, all these parts are connected. So you cannot have a suspension of just one part. It's a full evaluation. You need to have all the parts that are partially hanging out suspended in unison so that the different parts don't hang out by themselves. And case in point is the uterus, case in point is the rectum or the bladder. You cannot just suspend the front of the bladder. You have to suspend the top of the bladder, or if you've had a hysterectomy, the top of the vagina, because they're all connected. And the whole thing needs to be suspended in unison at the same time. That's one of the reasons that some of our old suspensions that we did vaginally would fail, is because you do a bladder suspension and then you would get the vagina or the uterus or the rectum falling out 6 months later. So we've learned a lot on that forefront on how to suspend everything that's hanging out just a little bit at the same time. How do you stop bladder muscle from contracting and leaking during, I think that's orgasm. Great question. So I'll have young people coming in, young ladies coming in saying, I leak with an orgasm, and that is an overactive bladder. So that is an overactive bladder workup. The only exception to that are positional. If you are leaking in certain positions and not during orgasm, you have to make sure you're not having stress incontinence. And we see that from time to time, especially after certain types of slings are done. So that is definitely an evaluation with your professional. Okay, let's see, Gwen. I'm up at night 8 times, sometimes just 2, especially when I take the Benadryl before the bedtime. I'm on heart medications for heart spasms I was having. So it's interesting that when you take the Benadryl to sort of relax you and go to sleep, you only wake up twice. But when you're up without it, you're up 8 times. A diary would be very helpful. I would question whether something else is waking you up and you've trained your bladder to use the bathroom that many times. Because if you can take the Benadryl and fall asleep and have a better sleep, and you're not wetting the bed and you're only waking up twice, then your bladder has the capacity to hold it, and there's something else going on. Next, I've been on pills for almost a year, and insurance has changed, and I can no longer take the medication. Yes, it's awful. These patients, I really feel for them. It worked 50% of the time, and what they do cover doesn't seem to work. I don't like to tell, how long is it safe to take the pills? So some of the older pills and some of the anticholinergic pills, we really are trying to get away from. If the pill's not working for you, I suggest you stop it and look at things that third line and pick something that will work a little better for you. If the pills are perfect, you can continue to take them. With pills like Ditropan, Detrol, some of the Vesicare or some of the older medications, I mean, there is a small chance you'll have memory issues. So we try not to keep people on those pills. Trospium and Gemtesa and Myrbetriq are 3 of the pills that don't have memory issues. And so they've been linked to less of that. And those would be the pills that we'd like to take long term. The problem is, Gemtesa is $500 a month. It's ridiculous. It's a newer pill, and there's no generic. Myrbetriq, no generic. Again, Trospium has a generic. It's just getting the insurance to pay for it. It's really a terrible. And I want you guys to know that your doctors are supporting you. We're writing letters. We're filling out forms. I mean, most of us spend a lot of time trying to get the insurance companies to help, and it's very frustrating for us as well. Can a forward tilted uterus cause OAB? Not necessarily, but this would be a situation where somebody would come in and say, hey, I've got overactive bladder when I get my period, or the week before my period. That would be a situation where I would be looking for that. But, a uterus can put pressure on the bladder, but, the uterus isn't very large. And as we get older and go through menopause, it kind of shrinks down. So I don't know that I've seen a normal size uterus push on the bladder to the point where you have overactive bladder and need to take medicines. But certainly a fibroid uterus, absolutely, that can do that to you if it's very large. Remember, fibroid uteruses can be, quite large and cumbersome, and you always got to make sure that's not what you have. Is urodynamic test okay for someone with prolapse 20 years after a bladder suspension? Yeah, absolutely. You are doing the urodynamics at this point. If you're having prolapse surgery, you're doing urodynamics to see if you leak. You're doing urodynamics to see if your bladder functions. It is a surgeon's sort of recommendation. Not everybody needs to get it, but it's a test that can be done and to check the function and make sure you have a normal bladder function. We're more interested in people who are going to leak if we're going to do prolapse surgery, because we'd hate to do prolapse surgery and have someone wearing pads afterwards. We try to prevent that by adding a sling at the same time, and sometimes urodynamics helps pick those patients out. Does cranberry juice or tablets help with UTIs? So great question. Cranberry extract, D-mannose is another one. They're all part of bladder health, and they can help. There's no FDA approved amount. There's no FDA, and even there's no, the health supplement industry is not FDA controlled. So I recommend not the juice, but the tablet. I recommend 1 or 2 tablets a day. There's a group of supplements called Eucora. You can buy it online. It contains some cranberry extracts and D-mannose for people who are getting recurrent urinary tract infections. Okay, let's move on. I've never been leak-free, never completely potty trained. I now have a hysterectomy, and it's even worse. So you need urodynamics. You need an anatomy study, so you need to look inside the bladder. You need urodynamics, and you need a very good pelvic exam just to make sure we are not missing anything else. Sometimes leakage does get worse after a hysterectomy. That's mostly stress incontinence. We tend to successfully treat that with a sling, but it needs to be worked up correctly. Do diuretics for blood pressure negatively affect OAB? They don't negatively affect it, but if you're making a lot of urine because you need to for your heart condition or your swollen legs, that urine has to go somewhere. So they don't negatively affect you. Your OAB pill isn't going to negatively affect your diuretic pill. It would allow you to just hold the amount of urine you're making a little bit better. I wouldn't advise that you stop the diuretic, by the way, and people think that that's crazy when I say that, but honestly, you need to talk to your cardiologist if you're going to change your diuretic, because there's a very good reason you're on that. We can work with you so that you can hold it more, but I don't recommend you stop the diuretic. I had a bladder suspension 22 years ago. I pee if I sneeze, but mostly I have to get to the bathroom. I don't make it completely. Pee just start. Yeah, so you might have stress incontinence, which is common after a bladder suspension. I take that back. It can occur. We try to pick those patients out. We try to study patients so that if you're going to be one who's going to leak after your suspension, again, we do a sling at the same time to prevent that. So if you've had a suspension and you're having leakage that you sneeze with sneezing, that's more stress incontinence. And so that needs to be worked up a little differently than overactive bladder. Let's see, let's keep going. I'm almost done. Oh, that's it. Oh, wait. I think that's it. I think I may have answered everything. Oh, boy. Okay, well, thanks a lot, everybody. I hope you enjoyed this. Thanks for joining us. Have a good evening, and we hope to see you soon. Thank you.